Welcome, my dear postgraduate students, for R.A.T.S, Racing Against Time for Students in Pathology. The topic for the day is a well-known one, Barrett's oesophagus. This can be seen in many contexts and connotations. Though it appears simple, my presentation today is a little complex beyond the realms of pathology. By James J. Goy. This is the normal histology of the gastroesophageal junction. I find the normal mature squamous epithelium, the slightly immature squamous epithelium of the esophagus, and the glandular epithelium of the stomach, the gastroesophageal junction. So please have this in mind. You are having an immature squamous epithelium, and as it goes up, it becomes mature. A lot of history and reading is there if time permits. However, I shall restrict myself to a few. Norman Rupert Barrett. He was an Australian-born British thoracic surgeon. And Philip Allison, a professor of surgery from Oxford. These were the people who first identified and defined the Barrett's oesophagus. So coming to the introduction of the topic, we have got, as usual, the subheadings. Think of the subheadings will take us to the answer. And these are the list of subheadings under which this particular article is dealt. And continuing with the introduction, the esophageal and gastric junctional adenocarcinoma is well prone. It is secondary to reflux as well as obesity. Metaplasia can be of the glandular type or the columnar type. And in this article particularly, the elements of endoscopy and biopsy surveillance come into play. Because in most cases, Barrett's oesophagus is not diagnosed before an adenocarcinoma, though it appears a paradox. If it were to be very easily diagnosed, then we could have prevented so much of an adenocarcinoma. And sometimes you find that a junctional carcinoma can appear anew. That is by default. And the incidence of malignancy is lesser in gastritis and metaplasia. Summarizing the slide again, esophageal and gastric junction is prone for an adenocarcinoma, secondary to a reflux or obesity. The metaplasia is usually glandular or columnar, and endoscopy and surveillance are important in the diagnosis. Sometimes it can appear anew and need not be accompanied by gastritis and gastric metaplasia. Whenever we talk about the metaplasia, there are phenotypes. Phenotypes means basically different. They are genetically different, and we have got three such types of phenotypes. One is a cardiac-like, fundic-like, and intestinal type. This I would like you people to kindly mention in whatever answer you are asked or expected of Barrett's oesophagus. One is cardiac-like, fundic-like, third one is intestinal type. And you find that the circumscription from the pathologist is required. He will have to knit everything together and then give a final diagnosis. Well, this is a very easy to follow picture. There is a reflux of the bile acid as well as the other contents into the esophagus, leading to a oesophagitis. And you find that the multilayered squamous epithelium is being replaced by a columnar type of epithelium. Initially, it is non-malignant, non-specialized. But sometimes you find that there can be an intestinal metaplasia also undergoing within. So we will have to look for these changes. If at all there is a metaplasia, whether it is benign or malignant, whether it is of the gastric type or the intestinal type, and whether it is going in for dysplasia or a carcinoma. What are the diagnostic features? A full thickness biopsy is required. It is mandatory. Generally, we are fed with a superficial biopsy, and the pathologist is in a paradox, though he sees dysplastic cells. There should be non-keratinizing squamous epithelium of the oesophagus. Only then we can say that it is a metaplasia occurring within the oesophagus. Otherwise, it can be just a gastric biopsy. There should be islands of immature squamous epithelium, as I had shown you in the first picture. And there will also be a mix-up of the squamous and the glandular epithelium. All these are required. Only then you can proceed with the diagnosis. And invariably, the Barrett's is a metaplasia of the intestinal phenotype. The problem here is, even in the oesophagus lower down, you can find a layer of columnar epithelium which can mimic a gastric epithelium. Therefore, we cannot call it a Barrett's oesophagus. And if at all you find cells such as the parietal and the oxytic cells at the esophagogastric junction, it is more of a stomach rather than an intestinal metaplasia. And if at all it happens to be an intestinal metaplasia, it can occur elsewhere in the esophagus rather than at the gastroesophageal junction itself. This is a little complex, but you will be able to understand it in the subsequent pictures. So this is a classical picture of an intestinal metaplasia. I am finding a mature and an immature squamous epithelium parent to the esophagus. And then there is a metaplasia. Metaplasia is the replacement of one adult type of tissue by another due to a varied differentiation. So here I find that there is obviously a colonic type of metaplasia and the glands are seen. So this is not gastric gland. If it is going to occur at such a site, there is no doubt at all between two folds of the squamous epithelium. This is a very, very, very important picture. Kindly look at it, and it is actually a blessing in disguise. How do you diagnose a Barrett's esophagus? As I mentioned earlier, it has to be a joint venture between the endoscopist and the pathologist. One without the other cannot make a diagnosis in this case. In this case, I find that there is a circumferential replacement of the esophageal squamous epithelium by Salmon pink mucosa, which is proximal to the gastric mucosa. That is, it comes first, then the gastric mucosa. This picture is very important. It is an endoscopist finding and an anatomical distribution of the blood vessel. At the junction exactly between the stomach and the esophagus, you have got a pauci-vascular zone, so lack of vasculature. And immediately above that, I find that the blood vessels are all arranged parallel to each other. This is called a palisading arrangement of the blood vessels. Palisading we are using in a number of other stages, such as schwannoma. And higher up, I find it is more of a network of a blood vessels. So a palisading arrangement, this is mandatory for the endoscopist to exactly locate where his endoscope is. Otherwise, you find there are other conditions, esophagitis, erythema, etc., which can be mistaken for a Barrett's esophagus. Biopsy hence is confirmatory. The challenges are, you will have to look for an intestinal metaplasia and the mucosal phenotype will have to be determined. Not only metaplasia, not only endoscopy, but then ascertaining the phenotype might also become mandatory. Now, this is the rule of the day. Those days, the final diagnosis will be based on the light microscopy alone. But then came the special stains, then immunohistochemistry. But now, without the phenotype, you cannot give a diagnosis. Electron microscopy, however, is rarely of use. So the endoscopist will have to exactly locate where the lesion is. And biopsies, here again, it's a paradox. Even among the endoscopists, you find that there is variation between endoscopists of varying experience and expertise. It always varies. Always, no, you find whether it is a radiologist or a pathologist or an endoscopist, experience and expertise matters. Never regret. If it is good, it is wonderful. If it is bad, it is experience. A nice quote. This is again a pure anatomical picture. I am finding the mucosal folds of the esophagus. This is obviously the gastric. And in the case of a Barrett's esophagus, you find that there is an indrawing of the squamous epithelium. That is what he says. And it is being gradually replaced by more of a metaplastic glandular epithelium. This is here. So whenever there is going to be a weakness of the sphincter, there can be a reflux of the acid leading to a metaplasia here. And in a pure case of Barrett's esophagus, it need not be exactly at this junction. It can occur anywhere else also. Population screening. Nowadays, many of us are doing thesis, we are doing this, that, etc. But then, how justified it is? What the comments are by the author is, it is not justified without clear evidence. So it has to be followed with evidence. Barrett's esophagus need not always be preceding a gastroesophageal reflux disease or following. And screening the entire population is not feasible. Taking a random study can also be disastrous. And what he says is, according to common sense, reducing obesity and cigarette smoking can prevent esophageal carcinoma much better than diagnosing a Barrett's esophagus. Prevention is better than diagnosis. That is what he says. So the common sense ultimately is not so common. We look for needles in the haystack. How dangerous is the Barrett's esophagus? There can be a cancer that is associated with intestinal metaplasia. However, there is no spatiotemporal data. This word is a little complex. They are using it anywhere from space up to genetics. Anyway, it is more of a genetic term. I am not an expert in it. We shall go to it at a later date. And it cannot be ruled out as an adjacent site may be positive. So whenever you get a negative finding, there can be another site which can be positive. And always a metaplasia need not preclude. It need not predispose to a carcinoma. And you will have to look for genetic and epigenetic abnormalities in the other regions also. This kind of a complex one, I've already explained in my Big Bang theory, but go back to it. That particular class is of extreme importance. Coming back to this, it is a simplified form. Here is a squamous epithelium, the normal one. It is being replaced by the metaplastic epithelium, in which I am finding a lot of this goblet cells may be intestinal metaplasia. This is a very simplified one. So spatiotemporal, the complexity we have seen. So how dangerous is the Barrett's esophagus? There is a requirement for an accurate assessment. Then you should have a knowledge of the mucosal phenotype. See how many times they have repeated this one. There can be evolution of the dysplastic clones. Evolution of the dysplastic clones, again I can explain. It will be low dysplasia in one region or a high-grade dysplasia in another. And it does not justify still the follow-up of a carcinoma. Other carcinogenesis also will have to be studied. So always a carcinoma of the esophagus is not secondary to a Barrett's esophagus. And as I mentioned in the first slide, columnar epithelium can be seen at the junction and it should not be mistaken for a metaplasia. Hence, its identification is illogical. So these are the dangers in diagnosing a Barrett's esophagus and the surgeon following it up. However, you find that adenocarcinoma normally is of a very low percentage, 0.13% per annum. Whereas in Barrett's esophagus, it is 11.3. So the number of times is almost, I think, into 100. So 100 times more common in a Barrett's esophagus. So this is a post-biopsy risk. And the dysplasia itself can be divided into a low-grade dysplasia, high-grade dysplasia, and early adenocarcinoma. So this is what I had mentioned as the Salmon pink in one of the first slides. So when the endoscopic puts in a picture, he finds that there are pale pink patches, which I cannot see very clearly. Now probably I am able to locate it. Is it clear? He is able to identify it. And he plugs in the biopsy, he can find out an intestinal type of a metaplasia in these regions. So post-ascertainment surveillance. These are all very difficult terms. Maybe to community medicine it is fine. Surveillance of the endoscopy and biopsy. And what they say is normally it should be done 3 to 5 years after every clinical symptom. If a patient has got reflux disease, 3 to 5 years. 6 to 12 months in a case of low-grade dysplasia. Every 6 to 12 months, an endoscopy will have to be done, and if necessary, a biopsy. Every 3 months when it is going to be a high-grade dysplasia. But there are no controlled trials for this. And early adenocarcinoma, there is a wide variation in the diagnosis. It has to be assessed and done whenever required. So look at the requirement of the endoscopy and the biopsy. 3 to 5 years as a random study, 6 to 12 months in low grade, 3 months for high grade, as and when required for early adenocarcinoma. The other requirements here are, it is not totally reliable, all the other studies. And doing an endoscopy for the entire population is not a cost-effective approach. More, we can rely on reflux and obesity. It is found more commonly in the Caucasians, and the body index and dysplasia go hand in hand. So these are all very abstract and difficult to standardize, but we shall mention it for the exam purpose. The uses of the endoscopy, I can find out an abnormal picture, I'll be able to localize, take a photograph of it, take a biopsy, whatever it is, I can visualize and come to a conclusion. Technical follow-up is there. I shall show you one of the pictures later on. And finally, take a biopsy, and most of the utterings are post-biopsy wisdom. This is again a very important slide. Please follow it up. The metaplasia on this side, let us leave it for the time being. So this is a metaplastic region in which I am finding a stem cell zone. Always you find there will be a basal layer, and then there will be a stem cell which has got a potential to differentiate into gastric or the intestinal or the esophageal type of epithelium. And this is a Barrett's gland base. So Barrett's gland base is over here, and above that you have got the stem cells. From the stem cell you find that there can be a metaplasia that can occur. And these are certain things. What are these words? They are all too small. So I just expanded it for you people. Kindly see that. These are all various markers which can be used. Students, you people are supposed to mention the markers for Barrett's esophagus and adenocarcinoma. So these are the ones over here. So mucosa 5, mucosa 2, etc. and TFF, tangential flow filtration. And lower down for the stem cell, you can identify the LGR, WNT target zinc. And T67, of course, indicates the growth and veracity of the tumor. And this, of course, is I'm finding a piling up, it is darkening, maybe a moderate amount of dysplasia along with metaplasia is seen. So dysplasia again, you find that there is no standardization among pathologists. It is subjective element. Over the past 25 years, it has not been standardized. And this has been repeatedly reviewed by experts. Dysplasia can sometimes be mistaken for reactive changes anywhere in the body. That is why the people say that you will have to look for irregular nuclear membrane, so on and so forth. If required, a rebiopsy will have to be done. And indefinite for dysplasia. What is your comment on this particular report? Rebiopsy can be done after administration of proton pump inhibitors. So there is always a transition between dysplasia and non-dysplastic clones. And sometimes abnormal mitosis can be given or found, and these are all certain clues for proceeding. So what are your comments again on the dysplasia? There are certain which can be used or which cannot be used. Negative for dysplasia, indefinite for dysplasia, positive for low-grade dysplasia, positive for high-grade dysplasia, intramucosal carcinoma. This indefinite for dysplasia, etc., cannot be used. It takes neither us nor the clinician anywhere. And negative for dysplasia is highly dangerous. As I told you, it can be multicentric. There can be dysplasia and early gastric, early esophageal carcinoma elsewhere. This is a high-grade dysplasia. I find that there is a hyperchromaticity. There is a piling up of the nuclei over here. Maybe this is a mitotic figure. There is a loss of differentiation that is over here. Sometimes you find that there can be a papillary process also that can be seen, but all are limited to the mucosa, hence the term dysplasia, high-grade dysplasia, or at the most early adenocarcinoma. And this subtle protocol, what he says is 4 biopsies must be taken every 2 centimeters in suspected cases. And if it is going to be a proven dysplasia, 4 biopsies every 1 centimeter. It is better than a random method of doing it. So every 1 centimeter in a case of dysplasia, we will have to take a biopsy. And this protocol is called the subtle protocol. And as mentioned earlier, there should be a perfect correlation, coordination, and procedure by means of the endoscopist, the laboratory expert, and the pathologist. There are other methods in diagnosis. This is what I said. This is Greek and Latin to us for pathologists. There is something called as autofluorescence imaging, narrowband imaging, then confocal laser endomicroscopy. All these are various terms or techniques which are being used. You people can mention that. And for narrowband imaging, you find there can be a vascular chain that can be found, and it indicates a high-grade dysplasia, 97 to 94% accuracy. This is called the Raman system. So this particular diagram alone, if you people can follow, it can be of great help to us. See what is happening over here. I hope you people are able to localize it, or I shall try to help you. This is an endoscope. Always concentrate on the most important things that we can understand. Scope means you are able to visualize, and endo means it goes inside, an endoscope. And you find that this is probably used to visualize. Look at this one, they are visualizing the lesion. And attached to it, there will be another element. So this will be fed onto a computer over here, and it is a computer that does the analysis. Whether it is going to be an endoscope or an electron microscope, you find that this will be mandatory. It studies the nucleus, it studies the gross features, it studies mitotic figures, etc. And then these are all being reported on the screen, based on which a final report is given. And as I mentioned earlier, a camera is also attached over here, with which we can take the pictures. Along with that, that will be the forceps for biopsy, which can be sent to the histopathologist. So this particular diagram, you people can understand, not very difficult. And it is mainly spectroscopy that is the base behind it. And hence it is called the Raman effect. The C.V. Raman, who has won the Nobel Prize for Physics. And it is a quote of his. I am a master of my failure. It's a very nice thing, no? Great person accepting that he is the reason for his failure. And if I never fail, I will never learn. And if we do not accept our failure, we will never learn. So advanced imaging, what I had mentioned in the previous screen was trimodal endoscopy. Trimodal means all the three are over here, and I would like you people to kindly mention it. Diagram will be very difficult, but very easy for you to understand. It is for detection of high-grade dysplasia, in situ adenocarcinoma, sometimes non-surgical treatment. I'll tell you why it is being done, and it is cost-effective. Earlier, this is the conventional treatment. Whenever you find a esophageal abnormality, you do a resection and send it for histopathology. And those days, without endoscopy, it used to be in an advanced stage, nothing else can be done. It was a conventional method of treatment. But nowadays, we never get such specimens. So, you students will not be able to identify classical lesions. Classical peptic ulcer, you will not see. Classical esophageal carcinoma, you will not see, because it is not allowed to extend to that extent. Instead, they use a lot of other markers. Biomarkers can be used, and there is a high risk stratification which can be identified in Barrett's esophagus. Genetic, biological markers can be used. Apart from that, ploidy. Ploidy means it's a number of chromosomes. There can be aneuploidy and tetraploidy, which indicate cancer over a period of 5 years. Flow cytometry. Flow cytometry itself, it's only for the size of the cell, and it divorces the DNA. That is, it cannot analyze the DNA content as such. Only the nucleus and the cellular size. Whereas image cytometry is of greater importance. It will be able to study some of the nuclear features, and there is some correlation between this and the genetic malformations. And the problems due to truncation and overlapping are there in this. What are the markers? TP53 is one of the markers. Tumor suppressor gene is another marker which can be used. And only thing is, you find that multi-central trials will be required for all these. Well, this is a superb picture that I have taken from Elliott Weisenberg, pathology outline. So there is a superb malignancy exactly at the gastroesophageal junction, an ulceroproliferative lesion, which touchwood you might never see in your life. And earlier, there used to be oesophagogastrectomy, but now you find that there can be organ beam coagulation, photodynamic therapy, endoscopic resection, and RFA, radiofrequency ablation. I would like you people to kindly mention all these modern methods of endoscopy. As I mentioned earlier, this is more of a talk on endoscopy rather than pathology per se. But now, pathology, endoscopy, genetics, special stain, IHC, electron microscopy, all go hand in hand, and the light microscopy is no longer the final diagnosis. The good decisions come from experience, and experience comes from bad decisions. Superb course. Thank you. I wish you all the best on a Teachers' Day, because you are all teachers.